Well, thank you all for being here today. Today's webinar is about considerations for providing clinical care in pediatric HEMONC BMT settings during COVID-19. We have a panel of excellent providers today that we're really excited that are here. So my name is Dr. Samantha Bentu. I'm a postdoctoral fellow with the Pain Treatment Service at Boston Children's Hospital. Dr. Woolheater, if you want to introduce yourself as well.
Yep, my name is Karen Woolheater. I'm a psychologist who works at the Nemours AI DuPont Hospital for Children in their Hematology Oncology department.
All right, and we will be moderating today's webinar. Today, we're going to start off with Dr. Cindy Carlson. Dr. Carlson is an associate professor at the University of Mississippi Medical Center and director of inpatient pediatric psychology services. Dr. Carlson received her undergraduate degree in psychology from the University of Florida in Gainesville, Florida, and completed her PhD in clinical health psychology from the University of Kansas in Lawrence, Kansas. She completed her predoctoral internship and postdoctoral fellowship at the University of Mississippi Medical Center in Jackson, Mississippi. Dr. Carlson's clinical interests include psychosocial adjustment and neurocognitive concerns of children with cancer and sickle cell disease. Her research program focuses on chronic pain and sleep disturbance in children with chronic medical conditions. Other research projects include examining brief neurocognitive screening tools in children with cancer and examining the longitudinal trajectory of psychosocial adjustment in families of children with cancer and sickle cell disease. Dr. Carlson, thank you so much for being with us today.
My pleasure. Thanks so much.
We're going to pass the baton to Dr. Carlson so you can pull up your slides.
Okay. It says that you have to unshare first.
There we go.
There we go. Okay, all right, great. Well, I'm Cindy Carlson. I am in Mississippi, University of Mississippi Medical Center, and I am the sole psychologist in pediatric hematology oncology, so I wear a lot of different hats. We have definitely been impacted by COVID-19 here, and I'll just talk a little bit about how our medical team has been impacted related to sickle cell disease, and then as well as our psychosocial care, just to kind of get us started. So, you know, when first outbreak, everybody is now wearing masks and gloves throughout the hospital. Our patients and caregivers all are given masks as they enter the hospital. We have limited just everybody on campus is limited, probably like everywhere else. Most of us providers are still on campus. We are functioning with full clinic capacities, but our caregivers are only allowed one caregiver for a patient. So there's a lot of different just kind of changes like that on campus. Students are not allowed on campus. All of our affiliated students are not allowed on campus. I'll talk about kind of what we've been doing for psychology via telehealth. We have still done some bone marrow transplants on the cancer side, but because sickle cell is considered elective, we have not been doing any bone marrow transplants over the summer. We had about 5 sickle cell transplants scheduled for this summer, and those have all been placed on hold. We also had gene therapy trials scheduled to get going and start this year, and those were placed on hold as well. So, so some of those more elective curative therapies for sickle cell have unfortunately been very much impacted by COVID-19. Within the hospital itself, our child life specialist, all of the activity rooms are closed. So any child that comes in with a pain crisis, is isolated to their room. Every family is isolated to their rooms. They aren't allowed to go walking across the hospital. They can go get food, but that's a lot of our food options have been shut down on campus as well. So all of that is very limited. And then within the inpatient floor, they've only been allowed to have one caregiver at a time, whereas they used to allow 2 caregivers. And initially during COVID, they were not allowing caregivers to switch out. So that was very challenging for our families, that, a parent was having to stay here a week, 2 weeks at a time and not get any respite, no ability to kind of go check on other children or switch out with work, things like that. So that was really challenging for our families, is challenging and an ongoing concern. They are letting families switch out now. Fortunately, our numbers are a little bit more stable, maybe for a while, but they are letting families switch out now, which has been helpful. From our psychology side, we do annual psychosocial screening with our children with sickle cell. We try to find them in clinic once a year, just kind of check in, screen for depression, anxiety, school concerns. And I utilize students to do that primarily, affiliated students, undergraduates, research assistants, and all of that has been shut down because I'm not allowed to have students on campus. So indirectly that affects patient care. We've not been able to screen families like we normally do for psychosocial concerns. We also, at initial time of diagnosis, when they first present to the clinic, we were doing the psychosocial assessment tool. And that has also stopped because I don't have the support with lack of students allowed on campus, and some other staff. We have less staff than we normally do because of COVID cutbacks and different things. So that's also stopped. That was one of the things that we were doing that was impacted as well. When COVID first hit, we went completely telehealth for the first month or two, I guess 2 months. And so I did, we were still having psychology residents on campus because they are employees, interns, on internship, and those students needed contact hours. So APA was allowing phone calls to count as contact hours. So we did put together a list of our sickle cell patients. We keep, clinical registry in REDCap. And so we're able to put that together, and the resident was going through calling patients to check in. So the goals of those screening phone calls were kind of like our annual psychosocial screening, but to check on school, to check on their pain levels, if they needed medication refills. A lot of those patients were not coming in for medical appointments because sickle cell was considered more elective at first. And so we would catch a lot of medication refills that needed to happen, or pain crises. Patients were trying really hard not to come into the hospital, so we were able to still encourage them to come to the hospital and pass along any messages to medical providers. For teenagers, we were screening for depression, and we were able to provide some telehealth services for some teenagers that were pretty isolated and having symptoms of depression. I'll talk more about this because a large part of my clinical job is neurocognitive testing and getting school IEPs set up for our patients. And, Mississippi is not known for its stellar education infrastructure anyways. And then we have our very high risk patients with learning disabilities, low resources. It was just a disaster. It still is a disaster for school services. So trying to check in with families and help out where we can as well with those. As I said, I do a lot of neurocognitive testing, a lot of neurocognitive support. We have hospital teachers that I work with very closely that help me get IEPs for our students. So we do a lot with the school system, and so trying to help our patients navigate that system during COVID. Our Head Start, our kindergarten programs, our early Head Start and our Head Start programs were closed down. They still are. And so a lot of our patients, again, that are low resource are getting very poor early education services right now. I had a patient that I spoke with this week that said they were getting 15 minutes of Zoom calls for twice a week for her 4-year-old through Head Start, which is, I guess, maybe better than nothing, but not very much. So that's really unfortunate consequence of COVID. Similarly, all of our schools, they canceled all of the school readiness assessments, annual assessments that they do, tests to pass graduation, they were all canceled. So that's been challenging for us as providers and parents and schools to figure out how to manage that for children moving forward. This slide was just this is our hospital releases that we use for our hospital teachers. We work very closely together. Our hospital teachers, after I do evaluation, initiate child find, and all of this stopped with COVID. All of my neurocognitive testing evaluations, children that I would refer for child find and IEPs, the school district shut down. There was nobody to refer child find to, so now we have a long wait list of referrals to be placed that we started working in August. IEPs and child find, they normally have set deadlines that they're supposed to follow. You know, within 2 weeks, they're supposed to do this, and within 3 weeks, this meeting is supposed to happen, and all of that, all of those timelines were off or have been off as well. So it's been very challenging getting children even referred for child find. So, and then more recently, as children are going back to school, Mississippi is not completely virtual. Some districts have in-class meetings, in-person classes. Some are virtual, and then some are optional. So we do have some districts that are 100% virtual, and then some are optional. Most of our children with sickle cell are choosing to stay home and do the virtual schooling. All of our school accommodations for ADHD and for learning disabilities, none of those really can happen very well virtually. So we've been trying as best we can to work with the districts, just reminding them of students' disabilities, of those accommodations that they do have in place if they have IEPs, and trying to help problem solve with families to get some services. Most school districts, if they're virtual, are simply doing like an extra Zoom class with the inclusion teacher. But again, you know, our children with ADHD and learning disabilities, that's very limited in what they're able to learn in that setting. So it's been a very big challenge for our students and our patients. So that's my initial presentation. I will end there. Oh, That's just a program that we were also asked to implement in the midst of COVID, which is a new monitoring program for our youth with chronic illnesses, which sickle cell fell under. And so we're having to try to figure out how to implement all of these new guidelines and procedures with a very different healthcare system right now. I will stop sharing and let next presenter.
Thank you.
Thank you so much, Dr. Carlson. Next, we have Dr. Tori Jones, who's an assistant professor in the Department of Psychiatry at the University of Pennsylvania and a psychologist in the Division of Oncology at Children's Hospital of Philadelphia. She is embedded in the bone marrow transplant and CAR-T immunotherapy teams, providing direct care to patients and families in both inpatient and outpatient settings. She developed a pre-treatment screening program to streamline referrals for high-risk patients and will be launching an ADL adherence protocol to decrease infection risk and length of stay. Teaching and training efforts involve medical residents and psychology practicum students and interns, and areas of expertise include behavior management, diversity, equity and inclusion, and palliative care. Thank you so much for being with us today, Dr. Jones.
Thank you so much for having me. So I'll go ahead and begin. Thank you for the introduction and for the opportunity. I am trying to figure out how I might advance my screen, and I'm hearing a message. Oh, there we go. Okay. So what I'd like to do is just to give a little bit of a sense. So on the bone marrow transplant unit, we are still operating as has been described before. We had a halted flow for a while because we weren't taking folks who were needing an elective procedure. But at this point, we're about 100 patients a year for bone marrow transplant and immunotherapy. And we're about in a similar place, although obvious relaxation of some of those numbers for COVID. So one thought is safety has certainly been a big thrust in our environment since the beginning of the pandemic. And so we are observing universal masking as well as universal eye protection at our setting. So all providers, when they're in patient contact, are wearing PPE. And of course, when we go to critical care, we're gowned and gloved. And then in terms of COVID testing for patients, that has been one issue that I hear a lot about from especially the smaller children who are on our transplant unit. So they're right now needing to have COVID testing prior to admission for their transplant. And then they're also needing to have another administration of COVID testing with each sedation procedure. So that happens to be something that has been pretty challenging for some of our families. So there also are reduced family gathering spaces. So in general, places like the Ronald McDonald House have been very careful about kind of holding on to the folks that were there and then needing to be careful about whether they could take any additional families from outside. And our spaces on our unit, in terms of places to gather with parents and families for therapy, or even places where we might be able to have families go and warm up their food, those areas are certainly reduced and the traffic flow is lower. And so in the way of telehealth, that has been another major addition. I think we've always had teams that were working on this, but then the sort of power fast forward button was hit when we needed to be able to develop these opportunities in very, very quick order. And so as a part of the team that was doing the inpatient video pilot, and we were able for a while to operate doing new patient visits and a number of other consultations and providing services for inpatients and outpatients. Right now, it's been shifted so that primarily inpatient care is done by our consultation team, our hospital-wide consultation team, but those of us in specific units, especially within oncology, are primarily doing face-to-face visits for any inpatient care, and outpatient care is typically now being done remotely using the electronic medical record as an interface. We've also begun to use other forms of gadgetry in order to be able to improve our ability to communicate with families. So we now are using Doximity, for example, to place our calls as though it looks like we're calling from our desk phone. And then we've been able to do things like, using the record for our interface, but we've also been able to do things like, sending messages back and forth to patients to try and help streamline our communication. We've been using Slack internally to be able to send messages quickly, especially when the video interfaces are not working properly, where the network happens to be down. So those messages happen quickly. We have an intranet service throughout the hospital that provides us with a number of COVID-based updates, and we've been receiving daily emails for COVID. I have had to be a little bit careful in my own sort of balance of work and life and stress, and trying to be careful about how many of those COVID-based emails I consume on a daily basis, or exactly how much content I'm allowing in. But we also have town halls frequently. So those are sort of enterprise-wide efforts in order to keep everyone on the same page. But going back to telehealth for a second, also licensure and insurance limitations have been another thing to keep an eye on for us. We've been trying to come up with ways that we might be able to certify ourselves or have more reciprocity, but certainly, those are things that are still developing across the nation. So those have been things that we've been keeping a close watch on. Many of us are temporarily licensed, for example, by being in Philadelphia and Jersey because it's just across the bridge, and trying to come up with other ways to be careful, to be following all of the guidelines while this national emergency is still going on, and then what we'll do when those dates expire. And then in terms of coordination of care, a few things that we've had in place on our unit is that we've been trying to work carefully. Starting in January, we implemented more of a psychosocial rounds that complements or happens right after our medical rounds. And one thought is that, child life and social work, the chaplaincy, and our creative arts therapists, and many of our psychosocial team members are a part of that. And it was wonderful in January when we got it going, and then it was completely necessary once we got to the point where we were just not on site anymore and not able to do those curbside consultations that we were so used to. So it began to be a really important tool. And what we do with that is that we send the minutes back to the attending, and our setting uses hospitalists. And so we use, we send it back to the nurse practitioners, the attending, and the rest of the team that's doing the rounding, so that they have a sense of where we're going with those portions of our case. So I want to now move to other practice considerations. One thought that I have is that we had to kind of redefine the term essential. Many of the folks that are on site and actively involved and engaged in care were wanting to figure out, like, do we have another person in the patient's room, for example, in the transplant unit, or do we hang back, and how exactly do we pull this off? And we ended up having a period of time where providers like occupational therapy, physical therapy, were not going in to do their assessments or their interventions. And then we have a period of time now where it seems like there's more of a steady flow of providers kind of in and out, and that changes with respect to risk. But generally also, for example, language interpretive services were not available in person in the beginning of the pandemic, but then that has started to be sort of more available now. And our video interfaces for language interpretation and our phone interfaces have been critical, but we're not always the preference, right? The idea was it'd be great to walk in the room with an interpreter, be able to provide culturally effective care. And so there had to be a couple of changes and adaptations made there. Many of us are deciding what to do. Do we go in every day, or do we have one day a week, for example, like I'm doing currently, where I see all of my inpatients on that one day? Or do we do, kind of a mix between working remotely and then working on site? And that's happening across oncopsychology in our setting. And then also being really careful to think about balancing the clinical content, but also the sort of administrative load that goes along with that. And when it is that we do our charting, or whether we maintain our typical boundaries when it comes to what a workday looks like, and thinking very flexibly about what a workday will really look like, and doing things at nights or weekends if that happens to be more reasonable, and being flexible about that. Programmatic adjustments. We had some programming that we were really excited about. We've heard Dr. Carlson share about a screening program that happens annually. Our screening program was to be implemented at pre-treatment. So all the families that are in preparation for immunotherapy or transplant will formerly received sort of a visit from one of the folks that was working with me as a research coordinator, would stop in during their education day, where they received the rest of their information about their hospitalization, and they would complete this particular sort of battery of measures in REDCap, including the PAT, the psychosocial assessment tool. And we found, unfortunately, that we were no longer available to do the in-person assessment. And when we tried to send out email links, we ended up with very few returns. And so not particularly shocking. And so we ended up having to design a feedback loop system whereby our bone marrow transplant coordinators were able to be directly in contact with families and following up with them to make sure that the psychosocial information was in fact obtained and able to be used to determine who needed more preemptive behavioral health consults. Another thing that we do is that we take that information and use it in concert with, so for example, if we have a patient coming to transplant from our existing liquid service, or they're coming in from an existing area of the hospital they're referred in, we would know what was going on and what was working perhaps on the liquid team, and then we would bring that information over so that they would have it available for transplant. So we began to do these virtual meetings where nursing and the attendings and multiple elements of their direct care team would be, multiple providers would be available to learn about what was working in these other parts of our hospital, so that when they came to transplant, there was more in place for patients and families who had intensive needs. And then other programmatic adjustments we started to do. Certainly we had to be very creative in neuropsychology in order to figure out how to implement testing. And that was something that took a little bit of time to come up with, but it sounds like they are up and running at this point, and constantly ready to pivot depending on what happens next. And care coordination and team cohesion, again, with things like rounds, but also trying to really focus on using our documentation in the most effective way, so that it cuts down on some of our need to kind of track down the other providers to the extent that we can. Let's see, we also had some delays. We had a program that we were hoping to launch, the one that was intended to reduce CLABSI rates and some of the other infection concerns. And we were coordinating with the pilot program, which was doing clinical trials out of Cincinnati Children's. And we were really excited to begin to launch that. We had just begun to launch something that was operating at Nemours around NG tube placement being kind of regular sort of standard of care after day +1. And that was a culture shift. And then the pandemic occurred. And then this other culture shift was going to happen where we were hoping to implement our program. So we certainly weren't able to do that yet. So the hope will be that at some point we will be ready to do another comprehensive program. But for now, we'll need to wait on that piece. And so launch delays. And then in terms of teaching and training, we have been a little bit creative. We've had the ability to do on-site care at this point, but closer to the beginning of the pandemic, we really were not able to have trainees on site. And so I've been working with a practicum student in a way that she can kind of, she can sort of add her face as another square on the electronic medical record interface, so that the three of us are all there, the patient, myself, and the trainee. And then there's another program that we've been using where she, for the patients who, sometimes we have teenage male patients who prefer not to be on camera. And so we'll find ourselves giving, just doing kind of a three-way phone call and merging the calls together using some of our software that's been approved for that. So those are just creative ways that we've been trying to get them involved and keep them engaged. And so far now, with this new training year, we've been able to do things in person. So that's been helpful. So now we are going to talk a little bit about content and elements of treatment. It's been particularly tricky to think carefully about our typical presenting problems and then pandemic related issues on top of that. But we've really found, I had a patient use the term, the new abnormal. And so I enjoy that term. And I think that it's very, very descriptive and very adequate for what we're dealing with. A lot of unpredictability, a lot of uncertainty, and that's part of the transplant experience in general. And then they're kind of now being asked to manage this other piece of it. And we find this very marathon related approach to something that folks began expecting to kind of give all their energy to and have it be sort of more of a sprint. And we're realizing now that the pandemic just augments all of that. Certainly lots of stress and anxiety. There has been this interesting element that I've heard of among the patients that I've seen, mostly the adolescents and the young adults, that people get it now, that somehow, the idea of always having to mask and always being worried about contamination risk, those are all things that now like everyone is apparently doing together, and that feels less isolating, but in a sort of weird way. And then now folks are very concerned about school. Most of the people who need specific services that are an augmentation or an addition, resources above and beyond what's offered at the basic level at school are really struggling with that. And many different kind of presentations for school refusal and frustration about being able to do school remotely, and then feeling isolated, of course, for not being able to interact and maintain connection with their typical supports. So second to last slide, I'm hoping to be able just to emphasize this flexibility piece of it, and that we all just kind of assess and adjust, and that's what we do in our practice, and that's what we're really having to do now in our programming, and thinking carefully about our clinical work. And so we just kind of follow our typical QI kind of method, right, where we're thinking carefully about getting information, understanding where we need to shift, and then making those changes. And then lastly, this piece here that came through from part of our wellness team that came upon some work that's being done out of Denver around just recommendations for providers around how to help ourselves. And so I can certainly make this available if it's useful later. And for the interest of time, I won't go through all of it, but that last piece about flexibility being key seems to be the real meta message that we really have to be ready to expect that things might not go the way that we intend, and just figuring out how to shift effectively. Thank you.
Thank you so much, Dr. Jones. Next, we have Dr. Victoria Cosgrove, who is a clinical associate professor in the Division of Child and Adolescent Psychiatry at the Stanford University School of Medicine. She directs the Prevention and Intervention Laboratory focused on studying stress and its involvement in the emergence of mood symptoms in adolescents and teens, as well as developing clinical interventions that may help minimize negative responses to stress. She also directs the Family Clinic, which trains grad students in psychology as well as psychiatry fellows in the specifics of family therapy. Over the last several years, Dr. Cosgrove's research interests have matured, and she has begun applying her prior work involving immune stress, responsivity, and mood to incorporate youth undergoing treatment for cancer. This transition was spurred by personal experiences with her young daughter's treatment for cancer from 2015 to 2017, as well as her clinical observations of other families with youth undergoing cancer treatment. She was recently awarded an NCI K08 award to study stress vulnerability, executive control, and emotion regulation in children and adolescents with cancer. While new clinical research projects have been stopped in their tracks at Stanford for the time being, especially where vulnerable clinical research projects are concerned, she remains committed and inspired to have an invitation into this sphere. Dr. Cosgrove grew up on the East Coast and received her BA at Yale University in 1998. When she was a sophomore at Yale, she became a peer counselor and quickly made an easy decision to devote her career to supporting mental health. After receiving a PhD in clinical psychology and behavioral genetics from the University of Colorado at Boulder in 2009, she completed a research fellowship in child psychiatry at Stanford before joining the faculty. She lives in Redwood City with her husband, Brian, and their four children, Xander, Isla, Declan, and Aoife. Dr. Cosgrove, thank you so much for being with us today.
Thank you very much for having me. I'm very excited to be able to join from my garage in California. We're all working almost 100% remotely, so we've transitioned our standalone garage into my husband's and my office. So apologies if any small people run in the middle. I am going to echo a lot of the thoughts and sentiments that have already been shared by Dr. Carlson and Dr. Jones with regard to how practice has shifted and things have been changed. But I'm also hoping to offer a bit of the perspective that's been sort of coursing through my brain from the beginning of how this impacts families and who are experiencing it. Given that I feel lucky that I'm can approach my work now not only from the perspective of a provider, but also someone who's very looped into the community and still in close contact with folks that are in transplant and receiving treatment and so on and so forth in the Bay Area. So in preparing briefly for this presentation, I consulted with some of them just to kind of get a sense of, how is this impacting their experience of care. Oops. Maybe the problem that others were having. Oh no, that worked. Sorry, I went too fast. So I called this communicating in times of crisis, and I think that that, of course, what Dr. Jones just mentioned with regard to your adolescent patients, maybe mentioning that suddenly people get it, I think is a theme that certainly we discuss a great deal in our family, and certainly gets discussed a great deal in the childhood cancer community, that there is a lot of overlap in the sense that while the whole world suddenly feels like it has cancer, and the things that take so long to not feel as though they are very odd behaviors to engage in, such as wearing masks to the grocery store, or putting a child back in the car and immediately hand sanitizing their hands, things like that are now things that we are all engaging in, or most of us are engaging in. Someone in the country is not engaging in it, but I think that that's a real shift. So in the hospital at Lucille Packard Stanford Children's, I think the enhanced cognizance of hygiene protocols has been something that's been very notable. Of course, in a sterile environment, they were always very front and center, but now it's across all spheres, including child life, anyone involved, as you both mentioned, in any sort of direct care or direct interaction, which was not always the case in a systematic way. So there's a real adherence to that, and I think that provides comfort to families, even if there weren't a pandemic. I think that's something that is quite comforting to just know is going to routinely happen, and people are going to follow rules to a T. I include this slide because I think, well, in the next one, I say expected family stressors during COVID-19, but again, I think that many of these family stressors for families are simply enhanced for those in the hospital during COVID-19. And that, again, it pertains to the, and both of you mentioned this as well, lack of visitors and the policy at Packard that only one parent can be at the bedside and no siblings. So that's a stressor. It's a stressor in general to, as we all know, to have rotating parents, have siblings in the room, but now having no option to see one's siblings in preparation or anticipation of a treatment or transplant or other procedures is something that is an added strain. Is not is a euphemistic term. I think it's a painful experience for folks to go through. The flip side of that, I think, is that in situations where families are perhaps not intact, or perhaps there are strained relationships, it can go the other way. And I do think that that's the case if a parent is not allowed to go and a child has a negative relationship with that parent, then that could be something that is supportive. But I think what strikes me and has struck me from the beginning is all of these psychosocially related constructs that our families all deal with, and they deal with oftentimes within the confines of hospital rooms or treatment rooms, things related to economic discord, unemployment, duress, working from home, fear. All these things have always been present, and now they're just augmented and done so also in more of an isolative way, right? But the flip of that is we're to the point of Dr. Jones's adolescent clients, there's a bit more of an awareness, I think, and we're all sort of paying attention a bit more to the things that were going on all along. The other thing I wanted to just talk about is related to communication with children around COVID-19 and how that's being carried out at Stanford Children's, or how folks are recommending it be communicated. You mentioned testing, that also is something that causes strain and stress, but often requires then explanation and education around that. There's also fear in families about what happens if a family member gets sick, and the effect that may or may not have on an immunocompromised child or a child in treatment. So I think that's, of course, shifted with the advent of COVID-19. There's I would say, enhanced communication around what it means to be immunocompromised, potentially at developmental levels that it may not have otherwise been perhaps recommended or perhaps encouraged, or parents would have felt comfortable with. And I think that dovetails just into non-cancer life as well, right? I mean, I find myself having conversations with my 3-year-old who has a regular language around the virus going around. I'm not sure she knows what that means, but it's something that she wraps her head around to explain how her world has changed. And I think, again, there's so much synchronicity is the word that I keep using. We could supplant the word, treatment, transplant. Can my family survive? Adding this in, I think, understanding that for our patients, this is something that is an additive strain and stress, but something that a familiar question that they've been asking themselves all along, and that the coping mechanisms and strategies that they've utilized, while some have changed, I think another thing that I have been thinking about and I've noticed, and you both mentioned as well, is the hospital milieu is very different, and things are available at variable levels, right? So for example, the shared kitchen, while it may seem like not a big deal to folks who are not living in the hospital, it's sort of a big deal to not have the shared kitchen. And so have heard from that, and restrictions around that have shifted a bit as this drags on, but initially that is something that was a large thing, and again, the lack of visitors, but really something that I think has shifted is that within our world is just even more emphasis on resilience, and that there is in fact already in place. In many cases, families have already developed a very sophisticated way to cope and navigate, and this just tasks them with doing so a bit more. And again, there's bumps in the road. I mean, this is all of our lives every day in and out of the hospital, but that there is a path through, and it need not be a perfect one. And this is just our lab, and we are excited to get going with our newly funded NIH project very soon. And I'll stop there.
Great, thank you so much. Thank you, all of you. I'm going to try to get back to our screen that has...
Oh, do I have to stop share probably?
Yep, and then I'm just going to go back. I know we've unfortunately lost some of our participants, and actually I'm going to leave just this part up for us because we're going to do a couple of questions, and I feel like it might be helpful for us to just be able to see each other. And either of you, Dr. Jones or Dr. Cosgrove, whoever wants to jump in or answer, both of you. We just had some questions that we had previously asked some of our SIG members to submit to help generate some discussion. But I know in some hospitals, there's been a big change in kind of the fiscal demands on the hospital, because hospitals have lost a great deal of money during COVID. And in some hospitals, psychologists or other providers are being asked to cover different areas or maybe take on extra patients. And I don't know if in your institutions, has anything really changed in terms of not necessarily financial pressures, but just how your hospitals are managing the deficits that have happened because of COVID, especially for clinical providers?
Dr. Jones, do you want to go first? Share at Stanford, but you're muted.
So I'm trying to kind of regulate my understanding of what's happening for providers. I know that different departments have had to be careful fiscally, and they've had to make their own cuts, and they've had to be careful about, so for example, we usually will have a particular meeting that happens every week where we're talking about what happened in clinic all week. It's sort of a rounding of what happened all week in clinic. And we used to have lunch. And that is not a thing that we can do anymore, right? Because we need to be very careful. And so things like that, right? Like shaving, where you can shave. I know there are some larger policies, and I don't know if I'm allowed to disclose those, but there are some ideas about like ways that they're trying to like mitigate the use of vacation time, or like kind of trying to come up with ways that people are kind of shifting in and out in a way that helps to save fiscally. And then I know that there are certainly places that have freezes in hiring, right? So like positions or promotions, that those are some promotions for, certainly not like tenure and promotion, but like promotions for certain things are having to wait. So I think there is a lot of that going on around the institution. And I also think that in terms of psychologists and what their caseload looks like, my understanding is that those of us, at least in oncopsychology, have pretty much maintained our regular caseload. I do know that in the larger sort of behavioral health system throughout the hospital, there are some folks that have been being asked to cross cover in other areas. And I know that in other psychosocial disciplines, there have been some kind of cuts made in terms of the amount of time or the amount of coverage that's available. So that's all been definitely challenging.
Yeah, and I think you, both of you in your talks made it very important about flexibility is key. And I think that for all of us, we understand that the financial impact is certainly huge and important in how we think about how we can move forward and support our patients. But I agree, each hospital is probably doing their own things that you're right. I don't know how much we can share, but I think it's the flexibility, and I think kind of either cross covering or understanding that you may have to, if a position was expected to open in a year, it might now be 2 years or things like that. Dr. Cosgrove, anything at Stanford that you've heard or that has kind of made it challenging in those areas?
Yeah, I think it's been interesting. So I'm embedded within the Department of Psychiatry in the Division of Child and Adolescent Psychiatry, and that's how we see. So we're not see patients, and so we're not embedded within the Department of Pediatrics, which I don't know how fiscally they're impacted. But I would say within the Department of Psychiatry, it's been sort of interesting on a clinical level that because we've now, I think you talked about this, Tori, the fast forward button on moving into telehealth. But I mean, I've been at Stanford for more than a decade, and we've been talking about this for more than a decade. And then all of a sudden overnight, like, whoo, like just do it. So I think that's actually, I know actually that that our clinical visits, and this is over and above just talking about in oncology or medical visits, but they've actually increased year over year from last 2019 because of this new ability to see people at bedside on their computers and see people. Now, does that come with some struggles? Absolutely. And, you know, is it perfect? No, but I think that, so folks have largely been able to stay within their roles, which from a psychology perspective, which has been very heartening, I think, to see, and probably a long time coming with telehealth thing. So.
Yeah, I think that's a great point. I think some of the silver linings, if we can even say that, is that telehealth has become so much more accepted. And I have families who would have never done telehealth before, even though I would have thought it would be very helpful because they don't have to come in, they don't have to be exposed to another hospital visit, even if it's outpatient, now are so open to telehealth. I have, as somebody else mentioned, like teenagers, even though they don't always want to be on camera, I've had longer conversations than ever because they're so comfortable over this platform. So I do think the piece that will move our field, I think a lot of psychologists have done telehealth for a while, but it's really moving forward much more quickly, and it allows us to reach more people. As you mentioned before, Tori, the licensure thing gets difficult, especially in Delaware. We're reaching out to Pennsylvania, New Jersey, Maryland, and our own state. So it's just more than ever brings up that kind of need for maybe more common licensure. But yeah, so just before we wrap up, because I know, Tori, you had touched upon it on your slide from Colorado, just if each of you could maybe give one like self-care tip, either professionally or even personally, that you've been kind of using to cope with. I know this is a super hard time for everybody, and with the increased need for mental health care for our patients and families, I think that then takes a toll on the providers. So just anything you would kind of parting words for self-care that you would recommend. And it can be for students or psychologists, trainees.
I guess I would.
Victoria, would you like to? Yeah, go ahead.
Sure. I mean, I think that it's a hard one, especially I think within our field. Sometimes we put a lot of pressure for us to do self-care, right? I guess it's, I think during this pandemic, I think I and our family have sort of approached it from the same way we did during my daughter's cancer treatment, which is that anything goes. So, so it's sort of a day to day. Every day is a new day, and the goal is to get through that day. And so, I think, Tori, you mentioned just the idea of the extreme flexibility for all behaviors and all things. So, extreme fluidity. I'm looking over at the door because I let kids wander in and out of every aspect of my life now, and so and trying to roll with that is our coping strategy. Yeah.
And very similarly, for us, I have a 5-year-old. And so one of the things that, we've been trying to do is, when it's very weird, like I think I had done this odd thing, and I'm not sure if I was trained to do this or not, but like I seem to have been operating as a professional away from my child for like most of my, sort of regular pre-pandemic life. I would do things after she went to bed. I would do things, when she was at school. I would have like this entire life that I would live, and I'd squish it all in, and then I'd try and be present with her. And I've had to just meld all of that together, which is so different than what my approach was originally. And just giving myself some grace with that. I definitely started teaching a seminar for our interns, and I was asking them to share with me, based on the seminar, I needed them to share with me what their most salient identity was. And they were sharing with me, these things about being a student and being, psychology, all these like very professional, awesome things. And of course, like in comes, this door opens, and in comes, like my 5-year-old. And I'm like, well, there's my salient identity, friends. Like I have these other things that I do with my life. And I think that would have been mortifying, before. And I think now it's just sort of like, and I remember the supervisors that I had who, who had also, sort of robust things that they were doing outside of academia or outside of the hospital. But I also can remember trying to be present. And so my point really has been, when my like work day is over, even though that's a very fluid concept for me right now, I do try and be deliberate, like once the nanny leaves, then I have, this concerted time with my kiddo, and I really want to try and be present and not connected to my pager or not connected to whatever this other thing is, because she's been, sort of doing something else all day. And I think there are times where I realize I'm here, but I'm not here. I'm here, but I'm thinking about the 25 things that I really would need to be doing as soon as she goes down. And I want to make sure that I challenge myself to be present. So I think I'm really good at sort of selling that, right? Like I'm really good at reminding folks that they could do that better. But I'm not the very best at doing that myself. So that's my self-care challenge these days, is just, can I really be in this moment with her? Or can I really be in this moment with the people that, kind of aren't related to what I do?
I think that's really helpful. And I think, as both of you mentioned, just kind of having your dedicated space and also being flexible, but also sometimes having your boundaries and realizing that just because work is, if you're at your home, that doesn't mean that it needs to be 12 hours, that you can actually stop and put it away or leave whatever room is considered your work room. Yes, and once I came back to the hospital, I think I've been back since about the end of May or early June. Actually find it easier to like power through the day and be here, or even if I'm here long hours, it still feels really easy to kind of then put those ends and beginnings on the day versus at home where it just kind of morphs into everything. And, you're walking by the piles of papers, or you're knowing you could hop on and do some notes or things. So I truly appreciate your time today. Thank you so much for joining us. And I appreciate both of you and Dr. Carlson joining in, and encourage everybody watching to log on to the next set of videos that we post for Pediatric Cancer and Sickle Cell Awareness Month. Thank you so much.
Thank you.
Have a great day. Thanks. Bye-bye.